Historically, labor and delivery units have derived their structure for the convenience of the staff that is working there, and it isn't always patient-centered. When team training has been introduced and a structure has been adopted by a unit, oftentimes it is a win-win for staff and for patients. The structure that is most useful to think about is three different elements. The first element is the core team. Individuals on the core team are the physician caring for the patient, plus the nurse caring for the patient, plus any other person that would be at the bedside, and of course the patient and her family. The second team would be the coordinating team. The coordinating team consists of the charge nurse, the anesthesiologist of the day, an obstetrician of the day, which is rotated among members of the department, so all obstetricians understand the pressures on the department at a given time, and a triage nurse, so that the team has an understanding of the patients that could be coming into the unit. What the coordinating team does is essentially operates as the flight tower at an airport. It understands what are the pressures on the unit. So if there are multiple cesarean sections that need to be performed or multiple inductions at a time there's a high volume on the unit, they can organize and decide what cases should go first and prioritize. The third type of team is a very important team, and that is the contingency team or the emergency team. At the beginning of any shift, two nurses are identified as nurse 1 and nurse 2 to be on the contingency team. In addition, obviously the physician who will be involved in the emergency, and we don't know who that will be at that moment, is part of the contingency team, as well as anesthesia and a surgical assistant. When a team is activated in this manner, it allows for a discrete number of individuals to handle the emergency that is at hand, and the rest of the unit is allowed to function in a safe manner. When a team is not in place, what happens when an emergency is called, often many individuals go to the side of the operating room attempting to throw out multiple Foley catheters or place multiple lines, and there's an overlap of resources while the remainder of the unit is left unmonitored. Having a structure in place allows a much safer way to provide care for all patients on the unit.